Let's see. So, good afternoon, everybody. I've got a special guest for you today, Dr. George Ibrahim. How are you doing today, Dr. George?
Chris, thank you so much for inviting me to this podcast. I appreciate it.
Yeah, well, this guy is going to knock your socks off people today. You know, people that know what we do here in the practice, we focus on structural correction and we work in the neurology, the spine and brain. But when people are in chronic pain, we also see a lot of endocrine dysfunction. And Dr. George has got his own amazing story and has developed a business model around it. But I think first I'd like to know what life was like growing up as George Ibrahim.
Oh my! Well, I grew up in literally a map dot town. Excuse me, Smithfield, North Carolina. It's just tiny, about 6,500 people. My dad was and still is. He's still alive at 94, a cardiovascular surgeon, and my mother was and still is. She's alive as well. Nurse, and anesthetist. You know, she gave anesthesia in the OR. So I grew up in a household that I heard about medicine all the time, and it was a fun time. I mean, this little town was we are known as we have the highest concentration or the most number of Eagle Scouts per capita, and it was small town living, and I ended up going to boarding school a junior year. I went to a high school. After that, I went to Davidson College, which is another small school in North Carolina, and eventually ended up at Duke for medical school and stayed there for residency, becoming a urologist. And then, so I've lived in North Carolina my entire life. And
your family is from the Middle East, is that correct?
My dad is from the Middle East. He's from Syria.
And did they immigrate here, or he was here himself?
Well, so he went to medical school in France, and then he was lucky enough to get a residency in the United States. And through his residency, he ended up meeting my mother, who was a nurse, and the two of them stayed in North Carolina. He never went back to Syria.
I love the upward mobility of America. You know, when people come here with opportunities.
I call myself the American dream. I mean, you know, an immigrant father who became a heart surgeon, married to a Polish woman, and I end up in Smithfield, North Carolina. It's, you know, this is the land of opportunity.
When was it for you that you realize you wanted to practice medicine growing up?
When I realized what my parents did, yeah, maybe 4.
So since 4 years old, you had your eye on the prize.
Yeah. Mm-hmm.
And are you an Eagle Scout?
Yes.
All right. Well, that's quite an accomplishment for people that know what that is. There's a lot of work. I was a Boy Scout myself and helped many Eagle Scouts do their projects, and you know, they put you through the paces to earn that. So congratulations on that.
Well, thank you for that. I was blessed. I grew up in a town that was very scout friendly and accepting and promoting.
Yeah, well, it's life skills, you know. Well, there's a code there, and they learn life skills that serve you, I'm sure, till today as well.
I think so.
So when you were at Duke, where did you pick up your practice focus? Like, where did you get the formulation of what you wanted to do with urology?
Well, I picked urology for a very simple reason. My next door neighbor was a urologist. My father was hardly home. He you know, being a heart surgeon, his call was brutal. The urologist was home all the time. Not all the time, but often. And in urology, there are very few emergencies. In heart surgery, there are a lot of emergencies. And so, you know, I looked at the two lives, and urologists operate. I wanted to operate, that was for sure, but I just did not want to have the call that I saw my father go through. And that's why I went down the road of being a urologist. It was a very exciting field. I got to be chief of the VA in Asheville, and I specialized in prostate cancer. So I was a urologic oncologist.
So you saw some tough cases.
Tough and fun. And the biggest thing was I got to teach, because all of the surgical divisions at this VA are Duke training division. So orthopedics, urology, cardiovascular surgery, all of them rotated through. So I got to be an attending physician teaching residents to come up through the ranks to be able to go out and do this on their own.
So you got the opportunity to give back a little bit.
It's fun to teach. And
how long did you practice for?
I was actively out there for about 15 years.
And if you don't mind, I think you had like something change in your health that caused you to transition to where you're at now.
I developed multiple sclerosis, and For those that are familiar with the disease, it's a neurologic muscular issue. And it got to be where repetitive motions became difficult. And, one time I got into trouble in the operating room where I got into the vena cava with a younger resident, and I had trouble sewing the patient up, the vena cava up, and realized I'm not gonna lose somebody because of my infirmity. And that's when I stopped doing surgery, and when told the chairman of the division that I would stay on until he could find a replacement, but I wasn't going to do open cases. And unfortunately, I had to leave the field of surgery due to inability to perform physically.
Yeah, obviously you're doing what you love. What kind of impact did that have on your life at that time?
Well, at that time, I was devastated. I didn't know what I was going to do. I was blessed that my spouse at the time was a physician, is a physician, and I was able to do some things on my own. So I got an MBA just because I'm a nerd. I like education, and that was a fun time. But I still wanted to get back into medicine. And a fraternity brother of mine was playing golf with another physician that went to Davidson, and this was an OBGYN. And the OBGYN had retired, and he had been doing bioidentical hormones since the day that they came out. I mean, he had more experience than anybody anywhere. And he wanted to make a business in his retirement of training other physicians how to do bioidentical hormones correctly, because he saw too many physicians that were starting to do bioidentical hormones do it without having a clue, or there'd be advertisements in doctor journals that would say, come to sunny Orlando for the weekend, start your hormone practice on Monday. And he was like, that's just not right. And as he's talking, he's telling my fraternity brother, he goes, but you know what? I need a partner in this. I mean, I'm getting old, and I need somebody to help me do it. And my partner said, I got somebody. I mean, I've got a guy, he went to Duke. He's a urologist. He's up in Asheville. I know that he's bored. You're an OBGYN. The two of you are going to knock the ball out of the tee. And that's how I got into doing bioidentical hormones. His name is Ron Brown, and he is a phenomenal mentor, and he knows bioidentical hormones inside and out, and that's where I got started.
That's a credible story. I think I'd like to open this up for people, because I think they don't understand the difference of all these hormone advertisements, that some of it's like the wild, wild west, and there's people like yourself that, I don't know if people know what a urologist does, but they work on your kidneys, and your kidneys are part of your endocrine system. So Dr. George is well attuned to everything that's going on. And he was saying that some people just take a weekend course and they're a general practitioner and start offering this to people.
Well, and so urology is the male and female urogenital system. I mean, the urology part of it, but then there is the genital part of it, and that's going to be on the male side. So I had experience prostates, testicles, penises. That's all part of urology as well. And so, I had the basis for all the anatomic areas, and the hormones are the same in both men and women. A lot of people don't know that, but men and women have the exact same hormones, just at different levels.
Yeah, I don't think people understand that either. I think they think just men have testosterone, women have estrogen, and that's it. And that's just not the case.
True. We all start as basically unisex, and then down the road, as we're developing, as an embryo, a switch goes off, and you become either a male or a female. But we start with everything all the same parts.
What did it mean to you to finally find something else that you're passionate about, getting into this hormone clinic?
That's a great question, Chris. Thank you for that one. Because people asked me that when I first got started, because they knew that I was a urologic oncologist, and I started to tell people, I used to save lives, but today I get to restore lives, because that's what I hear from new patients all the time, that they feel like themselves again. They're restored. And in the past, people used to think that your hormone levels went down because you aged. And today I tell people you age because your hormone levels go down.
Correct. So I think people need to hear that again. Can you repeat that for them? Because it's,
a lot of folks just think that, okay, I'm getting older, so that's why my hormone levels are going down. And I'm the guy that says, putting your hormone levels down is what's making you age. It's sort of a reverse of here's a great example. I was in medical school, and I was on the OBGYN rotation, and I was assisting on a hysterectomy, total hysterectomy, where you take out the uterus and the ovaries on a very, she was young. She was probably 38. And the resident told me, because I had to wheel the patient back to the recovery room because I was low man on the totem pole, said, make sure you put this estrogen patch on her in the recovery room. So I wheeled her to the recovery room, went back to the OR to do another case. When I'm wheeling the next patient back to the OR, the first patient's still in the recovery room, and she's screaming and thrashing all about. And I realized, oh, heck, I forgot to put that patch on her. So I put the patch on her. I go back to the OR to do a third case. When I wheel the patient back to the recovery room, the first patient's now coming out of the recovery room to go to her room. But now she's calm. She's sedate. And that's when, it didn't click at the time. Now that I'm a hormone doctor, that was one of the first things that hit me, that memory. I went, oh, I saw this 30-something years ago when I forgot to put the estrogen patch on that lady in the recovery room after surgery. But she was a 38-year-old. She said she felt like a 75-year-old would feel when she woke up because her hormones were gone abruptly from the hysterectomy. And that sort of goes back to what I'm saying. If you get rid of the hormones, that's going to make you age because that's how she felt.
So that's an extreme example, but I think that's super valuable for people that, like, as they age, start accepting less for themselves. And, as we started working together and I started sharing my journey with my practice members, I'm like, you don't have to age like your parents. And, I'm a vitalistic health doctor, but I support what you do because the research is there, and why not take advantage of it?
And I always remind patients, and when I give these talks, I'll tell the audience, this is putting air back in the tire. This is not weird. This is exactly what our bodies used to make, but in much higher quantities when we were younger. If you send a blood sample to the lab can't tell you if it's coming from, what I do here in the office or if it's coming from somebody's genitalia. It's not similar. It's exactly the same thing.
So transitioning into this piece of literature here, the #1 read book in my practice. I get questions on this every day. Maybe what led you to feel the need to write this?
Well, I'm going to first start with the explanation of the title. I'm a big sailor. My summers I spent at a sailing camp. I worked there as a counselor. I've sailed all over the world. I love to sail, and there's some things you can control and some things you can't. You can't control the wind, but you can control the helm. And when I see these patients in menopause, these women that are starting to go through menopause, they're like a boat without a motor out in the middle of a storm because it's up and down, and every day is so different. They're getting tossed about, and it's a rough road, and that's where the name of the book got started.
Well, I love the name of the book because I also love the expression I get, especially from the women when they read it. Coming from a male, like, oh, what does this guy know about menopause? And he's going to sail through this and everything. But when they read the book, I think it puts some different texture on there in what you explained. I know we had talked about earlier, you mentioned bioidentical, but I know previous where hormone therapy got a bad rap. There was even a nasty name of a drug given to people. I know you touch on in the book. I think this will help reframe the stigma that some people might have from past experience.
Well, so what happened was this. The government pays for a lot of our health care, especially in older people, correct? Medicare. And, we knew a long time ago that menopause wasn't just a bitch for both the woman and the people around her, but it was also deadly. Women don't really have heart attacks before menopause. After menopause, a woman's risk of a heart attack becomes identical to a man. That's a big deal. Osteoporosis does not happen to women before menopause. It's due to a lack of estrogen, not a lack of calcium. Women fall down after, they've lost their estrogen. They break their hip. They go to the hospital. They get pneumonia. They die. The heart attack risk. So the government's paying a lot of money due to these lack of hormones. So they figured, okay, let's give women back hormones. That way, we're going to save some money on Medicare by not being in the hospital so often. So they rounded up about 30,000 nurses. One group they didn't do anything with. One group they put on an estrogen and one on a progesterone, except they weren't estrogen and progesterone. The estrogen that they used was not human. It came from horses. It came from urine from horses. Think about this. Premarin had the nerve to name their drug just what it is, pregnant mare urine. It became the number one drug seller, the number one selling drug in the world at the time. Progesterone. They didn't give women progesterone. They gave women synthetic progestin. Only thing it has in common with progesterone are the first few letters of the name. Well, if you give a woman synthetic stuff and horse stuff, they don't necessarily do well if they're human. And these women didn't. And they got cancers, and they had clots, and they had heart attacks and strokes. The study was stopped, and all anybody heard was hormones were bad. Nobody bothered to yell, loud enough. Horse hormones in human women, or synthetic hormones in human women, are horrible. Today we have the bioidenticals, and they're completely different. They are what our bodies used to make. But that study scared so many people that around my age that they think that all hormones are bad. No, putting horse hormones and synthetic hormones in human women and men is not a good thing.
Yeah, when I read that, my jaw dropped. Just even the audacity of the name like that, and to think that that's going to work. Like this, like making a mockery of the entire situation.
Yeah, pregnant mare urine.
Yeah, so you touched on some, and I don't think people realize this, but as women's, and it happens to men, but different health problems. But let's say a woman's going through menopause and all of a sudden has a heart attack or falls and breaks her hip, like. The cost of that on the healthcare system is astronomical. In another life, I was a trauma device rep and putting intermenstrual rods down these hips, but sometimes we couldn't do it because they had so much osteoporosis. And if I'm hearing what you're saying right, that if we can do a little hormone therapy, we can change that relationship of calcium and estrogen for them.
So Dr. Brown, when he was practicing, he was in Charlotte, and he had a group of orthopedic surgeons that would send as many of their female elective hip replacement patients to him to get on hormones prior to their hip replacement, because they got so much better quicker. They were able to heal quicker because their bones were better due to being on estrogen when they were in menopause. I mean, he got a lot of patients that way because the orthopedic surgeons wanted their, the patient be in the best shape possible prior to surgery. And having brittle bones with a metal rod stuck in it's not a great thing. But if you can put somebody on estrogen for a few months to get their bone density up, you're going to have a much better orthopedic outcome. So, that he actually used to practice like that.
Wow, that blows my mind. I've spent thousands of hours at trauma conferences in the OR and never thought of that or heard someone of doing that. So it sounds like Dr. Brown was, like you said, the man in the forefront on this and well respected in your profession.
Absolutely. Excuse me, sir.
So when you talk in the book, I think men decline a little slower, and women, it's like you're cruising along and then poof, on a cliff. Maybe you could elaborate on that some.
So
what that's like.
Men lose theirs about. So let's just go through the menopause for women. They're going along, and bam, it just drops. And everybody, society understands this. Everybody's buzzing around. There's sitcoms that go talk about the menopausal woman. Andropause is the male equivalent. So men peaked about the age of 22. And then we're essentially like caveman. Caveman died in his early 30s, mid 30s. So after 22, 25, we begin to slow decline with our testosterone level. It's about 2 to 4% a year. So if you're a banker, you can do the math in your head real quick. By the time a man's 50, he's lost half his peak testosterone level. Every man by the age of 50 is by definition at half the level that he was when he was in his early 20s. By the time a man is 60, he's in his 60s, he's down to a third. And by the time he's 70, he's at a quarter. You can drive a Maserati with the tires a third inflated. I mean, it's going to drive. It's just not going to perform. But this air's been let out slowly, little by little, whereas menopause, it's more of just an impact. For men, it's just a slow decline. And men get to that age where they fall asleep after dinner. They're getting belly fat. They're losing muscle mass. An erection, oh, they haven't seen one of those in forever. They don't have the desire anymore. And all of this is due to lack of testosterone.
Yeah, the dad bod, right? That's what you're talking about.
Yeah.
So you got into business with Dr. Brown and kind of expanded. And then how did Biltmore Restorative Medicine transpire?
So, and Dr. Brown and I are best friends to this very day.
Oh, that's awesome.
He wanted to go down more of a cognitive, he was looking more at cognitive function. And what was happening with me as my patients began to feel better, they wanted to look better. And they would start to ask me, who does this in town, Botox? Who does this dermal fillers? Who does this kind of aesthetic stuff? And this was before med spas were on every corner. And the plastic surgeons and the dermatologists were so busy doing, their real stuff. And I didn't really have anybody to send them to. But I said to myself, I go, if I can make a bladder out of small bowel and a man can, be continent and stand up to urinate, and I've got that kind of skill, then I can figure out how to inject these fillers and neuromodulators. And so but I wanted to do it the way, this is like, it was not our mission statement, but I always wanted to be on the cutting edge. So I didn't just go to a random workshop. I wanted somebody from like LA or Miami. So I found the best injector nurse in Beverly Hills. And I brought her out here to Asheville to train me. And we spent several days live training. I had a bunch of volunteers lined up. And that's how I got into aesthetics. And after, did aesthetics and hormones for years, but then platelet-rich plasma began to be used by people other than dentists. Dentists have been using platelet-rich plasma for a long time. But other physicians, it just wasn't part of our world. Well, this Dr. Runnels, who's in Alabama, was talking to his girlfriend at the time about how wonderful this platelet-rich plasma stuff is. So your platelets do a lot more than just stop you from bleeding. They have all sorts of growth factors attached, because God figures that if you're injured, yeah, we need to stop bleeding, but there's going to be some things we're going to have to repair. So let me bring these growth factors to the area, and it regenerates and repair stuff. So he was injecting, joints and different other injuries in his practice. And he was going on and on in front of his girlfriend about how great this stuff is. It's from your own body. There's absolutely zero side effect because it's your own platelets. I mean, you're not a drug or anything like that. And everywhere he injected it, it made things better. And she looked at him and said, well, if you're telling me that everywhere you inject it makes things better, why don't you inject some into my clitoris and my G-spot? And he's like, what? She goes, yeah. Why not? So what he did was he called a buddy of his, because he had the PRP equipment, but he called a urology buddy of his to come over to do this because he figured the urologist knew the anatomy better. Well, when his friend was there, his friend looked at Dr. Runnels and said, if she's going to do this, I might as well numb you up and do it to you too. He goes, what? He goes, yeah. And she's like, what's good for the goose, good for the gander, ain't nobody. And so he spun their blood, got them numbed up. It doesn't hurt. And he injected, hers into her and his into his. And lo and behold, his erections became unbelievably better. Her orgasms became much better. She developed all sorts of different things that had not happened before, all to the benefit. Her G-spot, she had never had a G-spot orgasm. Then she started having them all the time. And that was the birth of placing PRP in the genitalia. And that's where the O shot, the orgasm shot, and the priapus shot got its name. And I found out about it, and I'm like, well, I can do that. I'm a urologist. So I went down there, and the long story short is I've been doing sexual medicine for almost 10 years now. So we started that pretty early as well.
Yeah, I find it interesting at your clinic, obviously you're dealing with the hormones, but you have the sexual side. There's so much more we could talk about hormones, but while we're here on the sexual side, when people are having troubles with like erections or orgasms, is that related to their hormones? Is that their anatomy, or what goes on there for people?
Think about it. If you're my age and you were in your 20s and you were able to perform several times a night, several nights in a row, Viagra and Cialis weren't invented. Yeah, we're not Cialis and Viagra deficient when we get to be middle-aged and older. We're testosterone deficient. I mean, that's the foundation of sexual function, are the hormones, and you know, putting guys back with more testosterone, and then if they want another added boost, you know, doing the platelet-rich plasma or other regenerative cell therapies that we have to help repair and produce more blood vessels and more nerves in the genitalia. But you know, hormones are at the very core. I mean, that is the foundation of everything.
The hormones is, no matter what, on the top bar.
Well, no, but you asked it that way. I've got one of my slides, and when I give presentations, one of the early slides is a picture of the pyramids. And the bottom, the stones are, you know, the boulders are big because it's the foundation. And across those, you know, boulders are so it says hormonal optimization. So I put it at the base of the pyramid, and then everything builds on top of it.
Gotcha. And that's, you know, one of the reasons I thought it was important to talk to you, because like, yeah, I see the depleted people, but it's not in the scope of my practice. So it's like, you know, we complement each other really well, because I see them depleted, but it, you know, outside of getting joint motion neurology, they still need to rebuild things that have been damaged for years.
And I want to come back to touch on some of what you just said and hormones, but I was talking about testosterone in men. I want to make a point. Yes, women, you know, there is a big role for testosterone in females. And unfortunately, ACOG, American College of Obstetricians and Gynecologists, has a statement out that they don't think that women need exogenous testosterone. There's no role for that. And I joke with my OBGYN buddies, you know, I go, you delivered a lot of babies. Do you think every woman got pregnant because it was a job? I mean, didn't you think a few of those women got pregnant having fun, doing the you know, having sex? That was due to testosterone, buddy. That's where you're delivering all those babies. So, you know, if you're a female, don't let, you know, your provider tell you that there's no role for testosterone in women, because you remember those days when your libido was up. Now, talking about the aches and pains, bones, joints, I've got one of my patients is also a good buddy, was a college athlete and a scholarship athlete. He played basketball at Clemson. And after he started treatment with us, hormones with us, came to me and said, George, I swear, I've been seeing you for like 5 years now. He goes, I've had chronic right knee problems ever since I was young. I mean, you know, teenage years, basketball. He said, my knee starts to hurt 1 week before your appointment. I'll pull my calendar out and look and go, yep, I'm seeing George next week. As soon as you put my hormones in, pain goes away. Doesn't occur until 3.5 months later. I'll pull it out. There's my appointment. So I see lots of aches and pains get relieved by hormones. And, you know, it's due to the anti-inflammatory effect that hormones can have.
Yeah, I think that's a major league point there. You know, Dr. Jack Kruse, I don't know if you know him. He's a neurosurgeon. He talks a lot about, you know, sunlight and cold thermogenesis. And, you know, he tore his knee up, and then he went on, realized it wasn't like an orthopedic thing. It was, you know, a nutrition hormone thing that was going on. And he actually went on to get his patients on like the paleo type of diet, getting more sunlight, cold therapy, and cut his surgical load down to like 90% because the body was able to heal itself from what you're talking about with the inflammation, along with what your friend was noticing. So for all those weekend warrior people out there and things like that, I think what Dr. George is talking about is very, very important for you to understand, because like neurosurgeons don't want to operate unless they have to. And this guy figured out, and Dr. George is saying the same thing. So any other stories like that to drive this home for people?
I like the way this guy put it. He said, Dr. Ibrahim, he goes, I'm telling you, my recovery time is unbelievably better. He goes, I used to be where I could do 1 set of squats a week. That was it. 1 set of squats a week. And then it took me a whole week to recover to be able to do that same, you know, do them again. He said, I've not only been doing 2 sets of squats a week, I am about ready to add a 3rd set because I recover so much quicker. And that recovery is due to the anti-inflammatory effect of the hormones.
Yeah, that's amazing to see the regenerate and get that work capacity up, because I think as we age, we lose our work capacity and we lose our independence. So you're noticing in real life cases that the work capacity is going up as people age, which is going to keep your bones stronger because you can keep more stress on your skeletal system.
And here's one for you. Google Scholar. Google Scholar is a search engine for scientists, physicians. And the rankings are not done by popularity. The rankings are based on the quality of the journal that the source came from. So obviously something like the New England Journal of Medicine is going to be way up there in ranking. If you type in 2 search words, testosterone and morbidity meaning major diseases, you type in just testosterone and morbidity and you hit click, and you look, and the gestalt or the overall, titles are all saying the same thing. Low levels of testosterone predict higher incidences of, meaning low testosterone levels, more diseases, more cancers, more heart disease, more chest or pulmonary disease, more mental disease, but low levels, more problems. COVID, this is a good one. This study came out a couple of years ago. In Germany, they did a study, and they were looking at data, and what they found was men admitted to the pulmonary ICU with COVID that had low levels of testosterone had twice the death rate.
Wow.
Twice the death rate. So, it's hormones are more than just the bedroom, is one of the sayings that we have here in the office.
And I think that's important for people to understand too, because I think they think of it just that way. They don't understand how the endocrine system really works. And what you said before with the hormones being on the bottom of the pyramid, the way it was explained to me is like, you get your vitamin D, which makes cholesterol as your steroid hormone to make pregnenolone. And then it goes the reverse pyramid of, I don't think people understand how the sun and cholesterol, while eating a healthy diet, makes all these hormones. And then, maybe you could touch on like what we'll see a lot. Everyone's society is kind of stressed out. You get that pregnenolone steal syndrome. They test high on their cortisol, but we're not fixing them on the top, we're fixing them on the bottom and propping them up.
This is good. This one might surprise a lot of people. So, because this is an issue in America, because we all watch our cholesterol. Cholesterol is the major building block of our hormones. So if you look at how hormones are produced, and the starting material is cholesterol. And then some hydrogens and oxygens are added, and you get pregnenolone, and you pronounce it way better than I do. And that's a precursor. And this is going to then go down on one pathway to DHEA. That's going to then split, and it's going to become either testosterone, estrogen, or progesterone. It could also, though, go over before that split and become cortisol. And now we're taking this away. Now cortisol is taking it away from making the rest of the hormones. So that's like the cortisol steal, or what do you refer to it as?
I've read it in the literature as like pregnenolone steal syndrome.
Yeah. But and as we all know, cortisol there's times when we need some cortisol, but too much of it is not a good thing, especially when you take it at the expense of the other hormones.
Yeah, and I think that's what I wanted to talk on. Obviously, you studied endocrinology, the kidney, where cortisol comes from, but when it takes that lateral thing, your testosterone, estrogen, DHA all get hit. So when people get tested for cortisol, it's not just rebuilding your cortisol. It's like we got to get these other pathways working.
Yeah, I mean, because there's only so much in the body, and if this molecule becomes cortisol, it's not going to be available to become testosterone, estrogen, or progesterone.
So listen up, people. This is why sunlight is important.
Yep.
And eating meat with fat is important, because it's a building block of matter in your body. So the low-fat diet, like, we talked earlier about the scam of healthcare using this horse urine for women. Well, they sold you a bag of goods with the low-fat diet, too, to keep you sick and unhealthy.
Yeah. I mean, think about, I tell people muscle mass, because this is a big issue with women especially women in menopause. You know, they get into menopause and they don't have testosterone anymore. And they kill themselves in the gym and they starve themselves and they just don't get ahead and they're getting fat. And I had a woman come in, she was a new patient. She said, Dr. Ibrahim, look, I'm not a closet eater. I'm not. She goes, I know wine's got about 125, 150 calories in it. I'm aware of that. She goes, but I'm watching what I'm eating. My trainer used to come once a week. Now she comes twice a week. I'm still going to the gym the other days out of the week. And she stands up and she puts her hands out. She goes, nothing's happening. Well, what's happening is she has no ability to put on muscle mass. Muscle burns calories 24 hours a day just to stay at body temperature. You exercise that muscle, it's going to burn 1,000,000 more calories. But if you don't have, so I tell them the 3 building blocks for muscle: resistance training. Walking's great, but it's just good for the mind, in my opinion. You need to do some resistance training. Next, protein in the diet. Lack of protein. How in the world are you going to put on muscle mass if you don't have, protein? And then third, testosterone. Without testosterone, you're not going to be able to do it. So it's 3 things. You've got to have all 3 of them. And, it's women that are in menopause don't have any testosterone. And they can compound it by then eating a low-fat diet with hardly any protein in it. And they're not going to be able to put on muscle. Muscle burns calories.
Yeah. So when people come to see you, I think you brought up a great point here. Is it more people that are just not doing anything, concerned about their hormones, or there are ones like this client you're talking about that they're doing everything they can and they're just seeing no progress? Where does the spectrum fall?
The vast majority, and that's another one of my slides, is there's a top hat and a magic wand with the big red X thing through it. And when I'm giving that talk and getting to that slide, I go, I'm not a magic wand. You need to be doing what you're supposed to be doing. I'm a tool. I'm going to here to help you leverage those habits that you're being frustrated by right now that aren't giving you a reward. You need to still keep eating the right way. You need to exercise the right way. But unlike before, when you had no hormones, you're going to see results. And the next slide says, make your workout work for you again. And that's by providing the tools that come from hormones to be able to do that.
So you try to avoid the codependent relationship by making them accountable for their lifestyle choices with, diet, exercise, sunlight.
Yeah. I mean, that's like, you got to live the right way. Don't expect just to show up in here. If you're not going to exercise and watch what you eat and get the right sunlight and everything else, then frankly, I don't really know if I want to be a patient, because that's not good advertising on my side. Yeah, well, I call it sweat equity. You gotta put into this, because obviously you spent your entire career doing this, and you want to do what's in their best interest. But if they're not helping themselves, then you're not going to want to be bothered with that, right? Correct. Well, I think this is going great. What makes your clinic different than others? We touched earlier that people are getting hormone advice from a lot of other different practitioners and things like that. What are some red flags maybe that people should look for when they're being, they're concerned about their hormones, they're trying to exercise, eat right, but then they're getting, you just mentioned earlier, there's a society out there telling them that it's taboo. Yeah. That they're getting this advice. So some things that make us different. We have 2 locations, Asheville and Greenville. In Greenville, congratulations on Greenville. For everyone who doesn't know, Dr. George has done so well here in Asheville. He's spreading the seed in Greenville. And I'm proud to say my daughter, Dr. Love, is the physician down in Greenville, and she is well versed in everything that we do. She's been up here for many months training with me. Now she's down in Greenville. But where I'm going with this is she's a physician. I'm a physician. We do have extenders, but unlike many of these franchises that you'll never see a physician ever, in our practice, you're going to see a physician. It might not be me. It might be my nurse practitioner, but you can be rest assured I'm in the next room. I know what's going on. Dr. Love's down in Greenville. So we're not one of those practices that, there's nothing but injectors. We have real physicians. The other thing is treating each patient uniquely. There are some practices that use labs are important. I don't mean to slight them, but that's not how you manage everything. You have to talk to the person. think about it. Every woman's hormones are different every day of a 28-day cycle and every day of a 9-month pregnancy. By asking and finding out when did they feel good during the cycle, when did they feel bad, we are able to get an idea of what kind of dosing we're going to be using, whereas a lot of places just use a lab value. And I could have two identical twin sisters, obviously born on the same day, they're identical twins, that weigh the same amount in my office back to back. And in one lady, I might put the lowest amount of estrogen I've got available. And in her sister, I might be putting in 50 times as much because everybody's different. But a lot of places just look at a lab and they determine things based on I tell my daughter when I was teaching her, treat the patient, not the piece of paper. And and people who've been to these other places that come here say it's like night and day because we're listening to them and we're adjusting for them. And then we use the labs to look for bad things that could happen and we make sure that those are corrected. But we listen to the patient to decide how to dose their hormones.
So you've noticed doing individual care with a good case history and understanding them allows you to get a better result specific to them versus just like, hey, this lab says this, we're just going to give you that.
Exactly. Exactly.
What kind of impact has that had on your practice? Like what kind of, results?
I mean, people go back. So they'll go back and tell their friends that are still going to the other practices, look, you got to give Biltmore a shot because I'm telling you, it's worlds of difference. I mean, this is what they tell us. So, physicians get a good idea of what's going on with like how many charts are being requested to be sent out versus how many new charts are coming in. And we're blessed that, our ratio is way more coming into our practice than ever leaving our practice.
Yeah, so people need to understand there's a difference. This isn't a knock on your general practitioner or your OBGYN. I think they all have your best interest, but this is what Dr. Abraham and his staff do all day long, every day. I'm
glad you said that, Chris, because my internist is the smartest doctor in Asheville. That's why I go to him. I mean, literally, it's why I go to him. But I told him, I said, Tom, I go, you're smart, but you don't know hormones because we weren't taught this in med school. None of us were. We were not taught this in med school.
You get like a little chart and you circle an answer and then that's it. You don't learn how to interact, right?
And I told him, I said, you wouldn't want me taking care of your congestive heart failure patients. We both went to Duke. I've got a clue, but I don't know what the heck to do. Well, you know what, Tom? I said, you don't know what you're doing when it comes to hormones. I said, quit doing your patient a disservice. I said, it's all I do now. And you're not being slighted, Tom. You're just, I can't do congestive heart failure because it's not what I do, and he laughs and he ends up sending them to me. But primary care, my Dr. Love did her residency in primary care, family medicine. And she told me, she goes, we didn't learn any of this. None of it. Zero.
Yeah, chiropractic's no different. No slight on people in my profession. Some people do more functional med or want to focus on hormones, but that's why I focus on what I do and value collaborative relationships with yours because it just people get a better result, they get better input, and then when you and I talk, we learn how to better identify things and how to refer stuff that might not be related. I think we touched on it earlier with the hormones for men. It's not always a big thing. There could be like a little thing here, a little thing there, but it adds up to be a 10 in their life, and then they accept less for themselves. They get frustrated. Women, it's kind of they're fine, and then off they go. So it's like these little things add up, and unless you know what to look for, you're going to dismiss it or misdiagnose it even. What's it like working with your daughter? That must be from a family physician. That's got to be rewarding.
I'm so proud of her. She knows what she's doing. She was here in Asheville for months, about 10 months. And now that she's in Greenville, I miss her. I mean, it was great having her in the house, because it is, my business. I go to Greenville often. I've got 2 grandchildren there, so I find every excuse in the world to go to that office. But it's just, who doesn't love seeing their offspring mature and do something like this?
Yeah, well, you lead by example, my friend. Excellent work. obviously we talked about what a typical patient would look like, and you've had a lot of success. What are some challenges you see in the market or in like some of the research of what's going on out there?
We do a lot of peptides, and unfortunately, the FDA and big pharma are, they're hand in glove with one another, and they're putting restrictions on a lot of peptides, not due to safety, zero, because there's no safety issues. It's due to big pharma wanting to be able to patent things that currently we've been able to get compounded. So that's not hormones, but peptides are a big part of our practice, and that's being hampered. I believe, more and more other physicians, other types of physicians are starting to accept that what we do here is not voodoo. It's literally putting air back in the tires. And when they see their patients that see us and then come back to see them for whatever, and how much better that they are, they're starting to send more and more of their other patients here. So that's been a very positive thing.
I think it's interesting, just thinking about what you're talking about. I've had family members hit menopause and have the heart attack, right? But then they get put on a statin, but no one's really talking about hormones, never mind bioidentical hormones. Like, imagine just by addressing hormones, do you feel that we would be able to use less pharmaceuticals? Like, what do you think about that?
Absolutely. Again, that's how all this got started. When Medicare, NIH wanted to see what we could do about women going through menopause, because that's when they started to get sick, and there's no question, if you had men and women on hormones earlier, you're not going to have to spend all this stuff down the road. And I do want to bring that out to women. Waiting for the signs of menopause, the symptoms like hot flashes, vaginal dryness, when you get to that stage, you're well into it. Women, we have women, as soon as they stopped having children, we've had women in their mid-30s start to see us, feel great, put on more muscle mass, get on progesterone, their mood gets much better, their cycles or periods get much less flow, fewer days. And then when they get to menopause, they're already being treated, and we're monitoring their estrogen, and we know when it's time to add an estrogen. But if you wait until you're having hot flashes and dryness, or you've gotten far into it, we can still fix it and make it better. But, you've put yourself at some risks of your bones are starting to get weak, and that started happening years prior down the line. Heart issues. So, if you're a female and you're thinking about any of this, if you're past childbearing years, then you're a candidate. Men, all you men are candidates.
Yeah, well, I think that's a very powerful message, and I'm glad you brought that up, because I think women wait too long and don't think that they need it until it's too late. But what you're saying, they can get in there earlier, start feeling better. I know here for me, I'll see a lot of females on their what I call their moon time or their cycle. They'll get a lot of cramping and things like that. What kind of differences are you seeing with the hormones with those situations?
Well, progesterone is your friend. So a woman comes in that's been cramping, having heavy flows, you put her on progesterone, which is the balancing act to estrogen, and all of a sudden her cramps are gone. If she was having a period for typically 6 days, that might get reduced to 3 to 4. If she was having to use X number of pads per day, or you can cut that in half. So, that's a big benefit.
Yeah, I see a lot of that. They struggle with it. And then the other thing I see on it is the migraines. Maybe you can touch base with the migraines, because it kind of goes hand in hand what we're talking about here.
Hand in hand. I mean, I do. I actually get patients that have talked to other migraine patients, and that's what they're coming in for. Be treated for the migraines. And what's frustrating is to them is in 2 days, they're making comments back to me like, why have I been going through this all my life, and now and I see you, and in 2 days I'm migraine.
Right, debilitating. They had changed their whole life. They can't work. Their family, they're down for the count. They go on vacation.
One of my favorite patients, that was what brought her to me. She said she had a hard time holding jobs, because if she did show up for work, she said she was useless. You know, if she stayed home, you know, she's writing her off like, you know, lazy. But her migraines were debilitating. She said, I haven't had a migraine since the second day that we got started on things.
That's awesome.
Yeah, it is. I mean, and you know, you remember people like that because when you remember, that's going back to being the oncologist and going, man, I got to restore her life. I mean, she's living again.
A lot of them have a lot of fight, you know, and I think what's harder with something like a headache, like if you break your arm, you see a cast, you get some sympathy. But when you tell people you have a headache, they just like automatically dismiss it or say it's emotional and all this stuff. It's not the case. You know, I do a lot of cranial work here in the practice. So, you know, when I get the cranium right, a lot of headaches go away. But earlier on, especially for some females, for me, some men, but mostly females, they weren't going away. And I didn't even think to look at the hormone system, you know, more recently after, you know, reading your work and looking into it even more, and I see they'll come on at different periods of their cycle and everything.
You know, going back to what you asked earlier about setting us apart, that's one of the first questions that we ask a new female. I go, when you were you know, having cycles, did you have migraines? And a good number are going to say yes, and we'll ask, can you recall, was it right before your period? Was it at this point in your cycle? And by listening to them, we know, okay, there is a very high likelihood putting her on estrogen is going to make her headaches way better. Or we can go, I'm going to use a type of estrogen that I can stop immediately because there's a chance that it might actually make it worse. 99% of the time, especially if they're middle-aged, the answer is giving them estrogen is going to make it better because by definition, their estrogen is low. But we're asking them a question, whereas the practices that just look at a piece of paper, that hadn't been asked. And that, you know, so that's one of the ways we are able to tailor our treatment is by asking questions like that.
Yeah, so I think people need to listen. Like, if your practitioners aren't asking you the right questions or detailed questions, you need to get someone that's actually going to listen to you and ask a few more questions on top of one line about what is going on with you.
And it's not just, do you get migraines? You know, we're like, when do you get migraines? Yeah.
And how often and the life effect. Because if you had a headache and you're a millionaire, you probably wouldn't care. But, you know, if you can't go play with your grandkids after working all day, you're going to be very upset about that. You know? So briefly, I just want to circle back to peptides. I think you could elaborate, but what I've noticed, anything that works, the government wants to get in on. And I think, you know, someone like yourself that works with a local compounding pharmacy has found a way to give people high quality health care for that's very cost effective and keep it in the local community. And now the government's coming in and trying to say that you can't prescribe these things, you know, and right back to where we started from the beginning of the talk with the hormone stuff, you know. So maybe you can talk about some of the benefits. I don't think people know what peptides are and what some of them are helpful with for them.
Well, Chris, you're about to open a can of worms. I could talk about peptides for 4 hours and get a third of the way through it. Peptides, by definition, are small chains of amino acids. Amino acids make up proteins, very small chains, typically under 40 to 50, we call peptides. And you know, these are just building blocks of the different amino acids arranged in a certain sequence. The growth hormone, body protection compound, BPC. This comes from the intestines. TB500. Well, when we were younger, we had a thymus that was active, and this thymus helped us, you know, take care of injuries. As we get older, the thymus goes away basically, and we don't have these peptides like that are coming from the thymus, like TB500, and you know, BPC and TB500 are healing peptides. Musculoskeletal injuries, heart attacks, they help the body repair. Growth hormone, if it was discovered today, would be called human regenesis factor. This is a true story. One of my patients who's knowledgeable on peptides and hormones has her sister, but also her mother. And her mother is in her 90s. And her mother, she wanted her mother on growth hormone enhancement and testosterone and estrogen because she wanted her bones to be strong. She wanted her to have muscle. She understands the healing properties of growth hormone. This woman started with us in a wheelchair. Now she's in a walker. This is 5 years later. I mean, I remind my only parents, you're not better off when you go from 92 to 93, like, the great grandchildren that go from 2 to 3. No, you're worse, Dad, when you're getting that old. This woman's gone from a wheelchair to a walker. But here's one for you. The nursing home or the assisted living home people are they're at a loss at how she's got brown hair now, because they know she doesn't have a hairdresser. She went from having white hair. Now her hair is brown.
Wow, so she's pulling less melanin from her system internal. She has more external to express.
And that's something that growth hormone does. But really, it would take to do anything about peptides justice, Chris. There's just so many out there for brain, for gut, for immunity, for repair, for sex, for fat loss. That's multiple discussions in and of themselves.
Well, now you just invited yourself back for a second show, so we'll do that. But maybe I think the one thing I like that you do, there's a lot of things, peptides, people can make them in their house, and then there's regulated peptides. Maybe we could just talk about the safety efficacy before we close it up.
This is the biggest thing. For those that have gone to taken biochemistry, you understand, and the ones who haven't, I'm sorry to bore you with some science, but peptides are like keys, like a lock and the key. They are their function is their structure. If one piece of those chains, one bond is broken, it's like a very complicated key with just one tooth bent a little bit, and you put it in the lock and it won't turn the lock. It won't work. That's the same thing with peptides. And there are people out there that are buying cheap peptides thinking that they're saving themselves money. No, you're not. You don't know what it's like. It's a bottle with the white powder. You put a fluid in it. You mix it up. You can't tell what those bonds are doing. You have no idea. The good peptides undergo a process that's much more expensive that make the bonds stable. Whereas the internet peptides, it might work for a day, but those bonds fall apart in no time. The ones that we get, they've been tested. Independent labs are testing the viability, the potency, and the purity, because what you get on the internet, you don't know if it's sterile, and the box says not for human use. So there's nobody to sue. You're the one dumb enough to inject yourself with something from a foreign country that God knows how much sterility it is. What we use, it's been inspected, it's sterile, and most of all, guess who the first person is to use every single lot? So, I know it's going to happen.
Well, this man practices what he preached, people. He's a wealth of knowledge. I can't thank him enough for coming on today. I just want to see if you have anything in closing for people, for what you want to see for people in the future. You opened up the show saying men and women both have identical hormones, just different levels. What can they do to help themselves here if they're looking to make a change?
Well, you hit the nails on the head, Chris. Good living, sunlight. I don't think there's a problem with a little bit of red wine every now and then, and behaving. You if you're eating correctly, and if you're being lazy. I mean, do you really want to take the elevator down a flight? No. So just little things add up, and I appreciate you giving me the chance to talk, and I so appreciate that. I look forward to
I can't recommend the book enough, Sailing Through Menopause. Dr. George's office has this excellent onboarding process to make you feel at home, welcomed, and he is on premise all the time. They have this amazing messaging system that I stole from my office that is fully interactive. There's no stone unturned, and they are on the cutting edge of what's going on here. And he does it himself first before he even offers it to you. So people got any question or concerns, we'll put your info in the box there, and I will see you having a little vino over the weekend.
Thank you so much, Chris. It's been a pleasure being here. I can't wait to see you again.
All right. Awesome.
Thank you.